Hello, everyone, and thank you for joining us. My name is Luke Strathman, and thank you for joining us. My name is Luke Strathman, and I am a Policy Associate here at the Abdul Latif Jameel Poverty Action Lab, or JPAL. I'd like to welcome you all to the 5th edition of JPAL's Research Webinar Series, which features new evaluations by JPAL-affiliated professors. Before we get started, please take a moment to make sure that your computer's microphone is muted to limit distractions during the presentation. Today's webinar features Michael Callan, an assistant professor at Harvard University's Kennedy School of Government and one of JPAL's newest affiliated professors. His recent work uses experiments to identify ways to address accountability and service delivery failures in the public sector, working primarily in Afghanistan and in Pakistan. His primary research interests are political economy, development economics, and experimental economics. And today, he will discuss recent research from Pakistan that looks at health worker absenteeism and whether the personality traits of doctors, inspectors, and senior administrators, as well as the political connections of health department staff, influence performance. This is ongoing work with several co-authors, and if you'd like the full paper or slides from the presentation, please visit the event page on our website or send us an email at webinar@povertyactionlab.org. Michael will present for about 30 or 40 minutes, and then we'll be pleased to take questions from our audience for another 20 to 30 minutes. If you'd like to submit a question, either during the seminar or the Q&A session at the end, you can click on the green bar at the top of your screen and then click chat and enter your question. Thank you again for joining us today. And now I'm going to hand it over to Michael.
All right, well, thanks everyone for joining. Today I'm going to describe a joint research project that's also work with Saad Gulzar, who's at New York University, Ali Hasnan, who's regularly at the Lahore University of Management Sciences but is currently on leave at Oxford, Yasser Khan, who works at the International Growth Center and is on his way to Berkeley Haas, and Arman Razai, who's a graduate student at UC San Diego. Okay. This project also reflects an active collaboration with a range of people in Pakistan, in the government, and at the World Bank. Zubair Bhatti, who's involved in a number of similar projects, was also involved in this one. Farasat Iqbal, who at the time was the head of the Punjab Health Sector Reform Program, was kind of instrumental in implementing this, and Asim Fayaz, who's currently a graduate student at UC Berkeley, but at the time worked for the Technology for People Initiative in the World Bank, was also kind of instrumental in pushing forward this collaboration. So just to quickly motivate the study and give you a sense of why we're working in this area, we're going to focus on a fairly common and intractable service delivery issue, which is the issue of public sector absence. So if you look across countries, ranging from Latin America to East Africa to South Asia, and look at the health sector, kind of absence rates in public health clinics are generally between 25 and 40%. So it's both a very common problem. It's also kind of proven to be a highly intractable problem. So a number of initiatives in recent years, some of which have involved academic collaborators, some of which haven't, have focused on this issue of health worker absence. And it's kind of some of the, I guess at best we have sort of mixed evidence that we can do very much to target this issue, working specifically through the avenue of incentives. So in our context, so in our independently collected data, we're going to find that doctor absence is about 68.5% using the same definition as in prior studies, where we define it as if I go to the clinic to look for a doctor during regular operating hours, am I able to find them or not? If we account for whether or not a doctor is posted and we kind of our data on whether or not a doctor is posted is somewhat imprecise, we're at 50% absence, which is still higher than what's found in other countries, but somewhat lower than the 68.5% number. So today I'm going to describe projects that explore two related issues regarding absence in Punjab. The first is I'm going to just provide some evidence on whether or not we can use information communication technology to address the problem, and we think there's some promise here because we live in an era where information communication technology, and in particular cell phones, are proliferating rapidly. And then the second issue I'm going to explore is how relevant are the personalities of the workers themselves, so those who are being monitored using the information technology system, how relevant are they to the issue of absence? Okay. So before I get to the actual research design, let me dig into the questions a little bit further. So first, a policy issue that we could imagine affects many organizations, including government bureaucracies responsible for service delivery, is that there are information bottlenecks. So in particular in Pakistan, in our context in Punjab, we're going to be dealing with an environment where there are 3,000 public health facilities spread across 205,000 square kilometers. So to provide a sense of the area, this is about 25% larger than all of the land area of New England, or about half the size of the state of California. And we can imagine that this is an issue that kind of affects lots of ministries and departments involved in service delivery. They have to deliver services across a pretty wide swath of space. And so it just becomes difficult to collect information across such a broad area. And so we think of information technology as opening up an opportunity to kind of get that information transmitted to a central location where it can be useful for decision making or for auditing, and also kind of aggregated in real time, so that there's just kind of a much better knowledge of what's going on in these facilities out in the field. So this creates opportunities to improve knowledge of utilization, the availability of facilities in general, improve the allocation of resources, both human resources and medicines, and also there have been kind of fantastic examples of using this type of technology to improve disease response. It also kind of presents the opportunity to increase monitoring. So this might provide a means of reducing bribe taking, or making it harder for people to ask for bribes for government services that otherwise should be free. Reduce resource theft, so possibly reduce people's ability, for example, to sell medicines that should be provided for free. And we're going to focus specifically on this issue of absenteeism. And so just to summarize quickly, the first research question we want to ask is, can we use information communication technology in this context where we know attendance is an issue to increase attendance? The second question, which is related to the first, is that governments by and large are the primary source of services for the poor, and kind of the largest player in this game. They're also comprised of people, people with personalities and people who react differently to incentives. Largely research and policy tend to emphasize issues of incentives. So how can things like changing wages, changing the probability that some type of malfeasance is detected, changing the penalty for that, how will this change performance? We also know from personality psychology, and now increasingly in economics, that personalities are kind of additionally relevant beyond incentives to performance. And so it may be, that having some understanding of the individual psychology of the people involved in being affected by these incentives could open additional avenues for improving service delivery. And so before I turn to the full research design, I just give you a few examples. Here we're going to provide some evidence that it might, a promising direction might be to, use knowledge of psychology to improve the targeting and the design of incentives. We know that, kind of a more nuanced understanding of motivations in the public sector can definitely help understand our kind of knowledge of public sector decision making. We know that kind of the profile of applicants who show up for a job in the first place, so kind of the profile of psychologies that we would see interested in a public sector job, is affected by the wage, is affected by the, by the nature of the job itself, where the postings are located geographically, and so on. And we also know from personality psychology that at least over longer horizons, personality traits are also malleable. So these are just some examples. I'm not going to provide any concrete evidence that any one of these is more promising than the other, but these at least provide some examples of additional avenues beyond incentives that we might think of when we're trying to think of, policies that might, or means of using policy to improve service delivery. And so, we're going to have a set of questions that I'm going to try to answer related to this. First, do we know, or can we find any evidence that individual personalities matter for worker attendance? Second, do individual personalities matter for how people respond to changes in incentives? And in particular, I'm going to look at a change in incentive created by a smartphone monitoring program. And last, do they predict which officials, so we're going to be concerned particularly here with more senior officials who are playing an administrative role, do personalities predict which of these officials will make use of the information? Okay. So broadly, to give an overview of the project, how are we going to gain traction on these questions? We're going to implement 2 experiments. They're going to be province-wide experiments in Punjab. The first is to implement a smartphone monitoring system, and the second is to kind of use the information that's coming from this system on health worker attendance and make absence data, so data on kind of particularly underperforming facilities salient to senior health officials and gauge their reactions to that information. We're going to collect personality data for essentially everyone who's involved on the public sector side in our experiment. So this is a large and representative sample of doctors, so 541 of about 560 who are in our experimental sample. The universe of health inspectors involved, so all 187 of them, and the universe of senior health officials who are involved, and so there are going to be 35 in our case. A nice thing about partnering with the Department of Health and the Punjab Health Sector Reform Program is that we were able to contact all of them kind of independent of whether or not they appeared in the clinic, so we don't have many concerns about selections as we start to look into these questions. And then we're going to have an independent set of performance data as well. So we'll independently collect data on doctor attendance, health inspections, and we'll have a measure of the degree to which doctors and inspectors collude to falsify reports, and I'll describe that in more detail in a moment. So in the talk, I'm going to go through a number of steps. Next, I'm going to look at kind of describe in detail the actual intervention itself. The intervention is called Monitoring the Monitors, which is a smartphone monitoring program. To describe the program, I'm going to have to give you some kind of very basic background on how the Department of Health works. So on this slide, we have kind of a very simple organogram describing the departmental hierarchy. At the top for the province is a health secretary. Beneath him, there are going to be 36 different senior health officials, which are also called executive district officers. So they will be responsible for health service delivery for an entire district, which could be, being responsible for health service delivery for several million people. Beneath them, there will be a health inspector. So they're going to have, they're going to be called deputy district officers, and they have responsibility for about 20 to 30 health facilities in their jurisdiction. And then in each of the clinics, there's going to be a medical officer or a doctor. And so this is kind of the way the hierarchy looks. The way the health inspection system worked prior to our intervention and the way it's going to be working in the controls is the health inspectors here, the deputy district officers, are going to be responsible for visiting every one of their clinics according to protocol one time every month. So they have about between 20 and 30 facilities to oversee, and they're supposed to inspect them monthly. And the prior system had involved them carrying a paper survey sheet, much like the type that we use in research when collecting data. They fill out the sheet, and then they would bring it back to be aggregated and presented potentially to the executive district officer or even to the health secretary to give a sense of what performance looked like. And so here we can see the potential for information technology to sort of mobilize this information more rapidly. All we've done is take that same paper-based format and implemented it using an Open Data Kit smartphone interface. So that kind of affords a few advantages. One advantage is that the data can be kind of mobilized in real time. An additional advantage is that it increases our scope to kind of give incentives for the inspectors to complete their inspections. So one thing that we're going to be able to do to this is we're going to be able to have the inspections be geocoded and time-stamped. And additionally, we're going to ask them to take a picture of everyone that they report present. So I will reemphasize that as I go along, but that's kind of the main changes introduced by the new system. So here's an example, a picture of us piloting this in the field. This is in an actual health facility, and these are a number of inspectors kind of getting their first experience with the app. To give a sense of what the app does, so after an inspector has filed a report, it's going to be added into kind of a constantly aggregating online dashboard. And so if we look, for example, here on the y-axis, we've defined this variable compliance, which is just the share of visits that are supposed to have happened according to protocol that have actually happened. And then along the x-axis, we have kind of a district-by-district breakdown. So what this allows is, the health secretary could look at this if he likes, and say, you know, which of my districts have kind of a rate of inspection that seems to be on path, and which of my districts have a rate of inspection that are kind of performing suboptimally, or it doesn't look like they're on path to meet their full inspections for the month. If they were to drill down a little bit more finely on the actual dashboard itself, you can get to the level of seeing specific reports kind of highlighted in a spreadsheet one by one. And so this provides some basic information you might be interested in, like is the medical officer, the doctor present or absent, and you know, kind of who else in the facility are present and absent, and then there's kind of additional data that can be drilled down to even beneath this. Importantly, for the incentives of the inspectors, this is going to kind of create both a geostamp and a timestamp of where they've been. So this kind of creates a sharper incentive and a little bit more visibility on whether or not they're completing their inspections. And then finally, we're going to ask the inspectors to take a picture with all of the health staff members that they report as present at the facility, so kind of creating incentives for them not to falsify their reports as they're putting them into the system. So next, let me describe the actual research design. So how am I going to answer the questions that I outlined at the beginning of the talk, and how are we going to evaluate the effects of this program? So we're going to evaluate this program using sort of the industry standard, which is a randomized controlled trial. And the way we've done it is we've randomly assigned certain districts to treatment. We've held out an additional set of districts who are then randomly assigned to control. We've moved one district entirely from the experimental sample. That's the district of Hanawal, where we actually piloted the technology to make sure that the smartphone system was working and the back-end system was working and so on. So once we kick that out of our sample, everything else is going to be kind of have a 50-50 chance of being assigned to treatment, which will allow us to establish the causal effects of the intervention. To give a sense of our sample, so where are we going to be collecting data on both inspections and on health worker attendance? We have 850 facilities. We selected them as a random sample from among the 3,000 facilities in Punjab. We've selected them such that they're kind of spatially representative as well, so this gives you a sense of the distribution of facilities across Punjab. These facilities are going to be responsible mostly for sort of frontline service delivery, so basic outpatient services, prenatal care deliveries, and kind of basic kind of first response health services. And one kind of an additionally important point is not only are we going to be able, through random and unannounced visits, determine whether or not doctors are present, we're also going to be able to look and see whether or not they've been inspected, because at each facility there's a register where the inspector is supposed to write down whether or not he's been there. And so this is how we're going to collect data on whether or not the facility itself was inspected. Just to create a sense of what these look like, this is an actual basic health unit in Punjab, so one of the ones, in fact, that's in our data sample. Okay. Just as a quick aside, to provide evidence that getting things right in rural clinics is relevant, the best that we're able to do is just look at the correlation between health outcomes in the 2006 DHS data, which were geocoded, and in our data. And so to quickly summarize, we find that kind of if you increase the distance between a respondent to the demographic and health survey and the clinic, you know, they're increasing that distance means they're likely to have fewer children vaccinated, less access to prenatal and antenatal care, less usage of the safe delivery toolkit, and kind of more likely to have young child mortality. And these correlations are particularly strong for respondents in the bottom wealth quintile. So as an aside, there is some evidence, at least some preliminary evidence, that these rural health clinics are actually very important for rural health outcomes. So next, I'm going to talk about just the results of the smartphone program itself, and then after that, I'm going to talk about the relevance of individual personalities for the smartphone project. So here are our results. We began collecting data prior to the rollout of the smartphone system. So back in November 2011, the data collection system and the inspection system was still the paper-based system where the deputy district officer or the inspector went from facility to facility recording this information on a paper form. We started in about March of 2012 and then went back to these same facilities in June of 2012. On the y-axis, we have the percent of the facilities in our sample that are inspected. The red line reflects the treatment districts, and the blue line reflects the control districts. And you can see that in June, there was a pretty sharp increase, so more than kind of a doubling of the rate of inspections, starting from a pretty low base of 22%. And bear in mind, according to protocol, this number should be 100%. So starting from a low base, we get to about 52% and then have some attenuation in our second and final round of data collection across the 850 facilities, which was in October 2012. Breaking this down and doing kind of a little bit more rigorous statistical inference, we find that there's differences, but in the last month, the difference is kind of edging into becoming not statistically significant. Okay, so at this point, I think what we've certainly established is that at least in the short run, this monitoring program created a pretty sharp change to incentives for inspectors. The next thing I want to ask then is, kind of how relevant are personality types just, in general under status quo incentives? So before we intervene, do personalities correlate with who performs well? And then second, I want to ask, do these things predict who will respond to the change in incentives induced by the program? And finally, I want to ask, does personality predict who will act on information? So in particular, I want to ask, among the executive district officers, so the guy at the top of the hierarchy for the district, if I give him information about which facilities there seem to be issues with, is he more or less likely to act depending on his personality type? So in the end of the talk here, I'm just going to provide evidence on these three questions. So what dimensions of personality did we measure? There's a 5-factor model, which is sort of widely used in personality psychology. It captures these 5 dimensions. So this is sort of standard across contexts where these type of data are collected. And below, I've put some example statements here to provide you a sense of kind of exactly what the respondents are responding to. So there would be several questions of each sort to give us back this data on their Big 5 personality index. Additionally, we're going to collect data on their degree of public sector motivation. So this is using the Perry Public Service Motivation Index. And so this is going to have 6 dimensions. And below, I've also given you a few example statements. Our goal here is to at least see if these measures can provide a proxy for the degree of motivation for working in the public sector. Okay, so let me turn to evidence now on the first question of whether or not personality predicts status quo performance. So what you see here, each of the red dots is going to reflect a different regression coefficient, or essentially a different correlation between what you see on the y-axis. So these are different personality traits, agreeableness, conscientiousness, extroversion, and so on. And then the dependent variable, or the thing that we're trying to predict, is whether or not a doctor is there in the first place. And so we're going to have report the standardized regression coefficient. So what this is going to tell us is, if I were to move a personality type in the direction of being more favorable, so say being more agreeable is a favorable trait, what does that predict in terms of doctor attendance? And so, for example, with conscientiousness, if I were to move a conscientiousness score 1 standard deviation, this predicts about a 7 percentage point increase in the rate of attendance. Likewise, with public sector motivation, if I were to move that 1 standard deviation, the red dot tells us that this predicts about an 8% increase in attendance. An additional measure that we can look at is this measure of collusion. So a quick note on how we construct this measure. So we are going to have independently collected data on whether or not the doctor is present, and we think that data is pretty trustworthy. There's also going to be data coming in from the smartphone system. So this is the official record, which is about those very same doctors. And so we can ask ourselves, is there a case where we're going to visit this facility 3 different times, make an unannounced visit over the course of the year? If they are absent each of those times, but present in every single official record, then we say that this is a proxy for them having colluded with the inspector to falsify the record. And so what we have in mind here, recall that during the visit, the inspector is going to call all the doctors together and ask them to take a picture, what we have in mind here is potentially that they call ahead and say, we would like you all to come. We're about to do an inspection, and then we can take a picture, and everything will, look good in the system. And I think to some degree this measure, which admittedly is just a proxy, is validated somewhat because it actually is predicted a lot by the personalities of the doctors who would be party to this. So, for example, the Big 5 index is, and all in the right direction. So, if a higher Big 5 index is more favorable, having a lower Big 5 index means that doctor inspection collusion is more likely. So again, we find kind of in the controls, without talking at all about the change to incentives introduced by our smartphone monitoring program, it seems that personality strongly predicts who's involved in this type of collusion. Okay, so let me summarize and just give a sense, at this point of kind of how much does this really matter? So, I've shown that a 1 standard deviation increase predicts about a 3.7 percentage point increase in attendance. It's pretty big with the 1 standard deviation increase in Big 5. Importantly, so a natural question is, are these personality measures any more useful than other things we know about the doctor? For example, how long they've been working at the clinic, how long they've been working in the health sector, and so on. And we don't have a rich set of data, so we only can compare this against a few things that we have where we have information about these doctors, but it looks like nothing else we can find comes anywhere close in terms of the predictive power to personality. So in our comparison, at least, it seems like personality measures are kind of much more important. To give a quantitative sense of how much this might matter, we can do the following thought experiment. So imagine if I had the full distribution of personality types, and I were able to kind of replace the bottom quartile in terms of kind of being unfavorable, and replace them with the average. So just take the bottom quartile of doctors, the bottom performers in terms of personality, and replace them with the average. This, depending on which personality trait you're looking at, this would mean about kind of between 5,000 and 10,000 more patients being seen across Punjab in every month. So in the sample where this would be relevant, that's about an 8 or 9% increase in the number of patients being seen. So anyway, it looks to us like, not only are these things correlated, but they're correlated in a way that's substantively important. Okay. So now let me turn to the next question. So getting back to the smartphone monitoring program, are we able to predict who is going to change their behavior when we introduce the smartphone program based on their personality type? And the answer is yes. So this figure is going to give us a sense of where are the treatment effects coming from in terms of people's type. So along the y-axis, we just have people arrayed according to their Big 5 personality types. So the people on the right-hand side would be those with the most favorable traits. The people on the left-hand side would be the least favorable traits. The blue line running across is the inspection rate among the controls. The red line running across is the inspection rate in the treatment, and we see that the treatment is everywhere above the controls, but the effects especially are localized in the middle. So anyway, it looks to us like, the best we can tell, so the black line running across is kind of the difference between the two. The response is going to be, stronger for people with more favorable traits, and even maybe is a little bit, U-shaped. So it may even be that it's kind of localized to folks that are kind of in the middle of the Big 5 distribution. One way to think about this intuitively is it may be that incentives matter a whole lot for people who are kind of on the margin of going to work, but if you're very, very motivated, then the change to incentive doesn't really seem to matter. If you're very, very unmotivated, the change to incentives aren't going to matter a whole lot. But if you're in the middle of the distribution, then this is where it's relevant. Breaking it up by index, we observe a similar pattern, and sort of strikingly for emotional stability, this seems to be kind of very, very stark. Okay. And so let me turn to the last question and conclude, and then I see a number of questions in the chat window, so I'll turn to those next. So does this predict who will act on information? So to test this, we introduced a small manipulation into the dashboard, and the purpose of this manipulation is just to make the data on health worker absence salient. And so what we've decided to do is, if a report comes back with 3 or more of the health official or the clinic level health officials absent, we're going to flag it in red. So again, the main intervention here is to just make this data look more salient to people who are using the information from the dashboard. And so in our case, this would be the executive district officers. And so what this gives us is it gives us, so again, this is information that's coming from the health inspectors, is being channeled to the executive district officers and the health secretary. And what we're trying to do here is introduce a feature into the data that makes places that are underperforming more salient. And so let me describe this figure. So basically, this is a test of whether or not this matters. On the x-axis, we have the number of staff who are absent. And remember, we've set this up so that the red flag kicks in at 3. So that's going to be kind of where the treatment applies. And, looking across any of the other thresholds, so moving from, white to white, so from 0 to 1 or 1 to 2, it doesn't seem like doctor attendance and our subsequent independence of visits are much affected. Whereas moving from 2 to 3, there's kind of a drop in the direction we predict, and this winds up being statistically significant. And also kind of substantively important because, it's a reduction of, about 20 percentage points or so. And so one additional point to make here is that, this is in fact highly localized to the executive district officers who have favorable big 5 personality types. So moving about 1 standard deviation predicts like an additional 20 percentage point reduction in doctor absence. So let me quickly conclude and then turn to these questions. So, on a very broad level, this is an intervention that really didn't take all that much and wound up being pretty cost effective. I think one of the main reasons for its effectiveness is we're using the pre-existing government inspectors. So we're just kind of embedding this and activating the existing monitoring system rather than creating a parallel system, which would require us to set up potentially phones in every one of the 850 facilities. In our case, with about 90 smartphones, we were able to actually get a lot of data that was relevant sort of in half of the province, in a pretty big province. The second, related to the final set of results I showed, even this simple manipulation of kind of making data salient to the senior officer seemed to have big impacts. So it seems like, there is potential here to mobilize data using technology and have it at least create some impacts. A second and broader set of conclusions related especially to the personality results is, we see here that personality predicts kind of a range of performance for different levels of bureaucrats, ranging all the way from the doctor up to the executive district officer. So across tiers, this seems to be relevant. And, the magnitudes were, to my mind, surprisingly large. And so, it's enough here to suggest, given the body of work, by other JPAL affiliates and others, that, we know that we kind of, who shows up for a job in the first place and how they make decisions is related to their psychology. It seems like this, at least opens the door for further research and further investigation into thinking about psychology as we think about kind of the relevance of incentives as well. Okay, so with that, I'll conclude and I'll turn to questions.
Yeah, thank you very much, Michael. We're now going to take questions from all of you listening in. As a reminder, you can submit questions for Michael by clicking on the green bar at the top of your screen and then clicking chat and entering your questions. We may not have time to get to everyone's questions, but I will try to bring out the topics that are being raised frequently. And to get things started, we had a question from Sean asking how easy or difficult was it to get the technology working smoothly? Were there any major implementation issues with the technology?
So on this one, I have to give some credit to the set of collaborators that I indicated at the beginning, so Asim Fayaz and Zubair Bhatti. By the time we stepped in, the technology was pretty mature. We did a short pilot in Hanawal district, and broadly we were pretty satisfied. Sometimes we would have issues with the dashboard not logging data correctly. Sometimes we'd have connectivity issues, so the smartphone wouldn't be able to upload the inspection reports until the inspector was back into better network coverage. Since then, we've done this actually in a number of different countries and in a number of different applications, and my experience in terms of kind of the actual technical development has been quite varied. Sometimes it works really seamlessly, sometimes there are really, really thorny issues that take months to work out. So I know that, but broadly, I think with a reasonably good team of developers doing something even kind of considerably more sophisticated than what we've done here is really not that hard. And bear in mind we were a pretty small team with a pretty small budget, so it was really just kind of the 5 co-authors and a small team of developers, and we didn't have big issues implementing this. So for a larger group and better resource group, I don't think an initiative like this is much of a challenge.
So somewhat related to that, we have a question from Noor. Was there any resistance to using smartphones over the existing paper monitoring system?
So that's a great question. There was some initial resistance, but there was also kind of a large constituency that said we feel like we are doing our inspections, which contrasts with the 22% inspection rate that we found at baseline. But they said we're doing the work and we'd love to have it documented. And so, I mean, this was something that came through the Department of Health. There wasn't a lot of scope for people to resist, but generally, I think it was embraced. But there was a point to which we could push it. So something else we thought of potentially introducing was beyond just introducing the smartphones. We might also, for a subset, randomize when and where they would be inspecting. So kind of make the inspections truly random. And this would, at least reduce this issue of collusion that I identified in the presentation. It looks to me like, at that point they just said like this is too much, and you're going too far in terms of changing our incentives. So there wasn't heavy resistance on the front end. And in fact, actually, one thing that's important here is for the more senior folks. So, for example, the executive district officers and others. They, at the more senior levels, they actually were quite eager to implement because they wanted this information. They thought this information was helpful and actionable in doing their job, and they don't particularly benefit from having, and if anything, it's kind of a cost to them to have high absence rates in their jurisdiction. So I think it was very incentive compatible in terms of being something people liked at more senior levels.
Great, thank you. So now we're going to move on to a question from Saifullah that asks, how did you randomize the sample and the visit? So thinking about the methodology.
Okay, so the sample, I guess there's kind of a few dimensions of randomization. The first is to draw a representative sample of facilities. So if I go back up, but to draw a representative sample of facilities, I need that to be randomized, so randomly selected from the full set. And so to draw that sample, I just had a list of all of the facilities that was put together by Punjab Health Sector Reform Program, and then we drew a random subset off of that just using a computer with a random number generator. Likewise, for assigning the districts to treatment, so basically what we want is we don't want to select districts where a favorable outcome is more likely. We want to make sure that everything is comparable ex ante. And so what we've done is, again, just to use a random number generator in a computer program to select which districts are going to receive the treatment. We weren't able, so I want to be clear, we didn't randomize when and where the visits could happen. So after an inspector had been assigned to having the smartphone, he had full discretion over when and where he did his visits. That was something we wanted to affect, but was kind of thought to be a step too far in terms of interfering with their normal course of business. So the visits were not randomized.
Great. So another question from Noor, based on this study, do you think there's potential to use personality testing to hire other types of public sector employees?
So I think this is a tricky question. So I think there is some scope for it. I mean, certainly this is done by a number of government agencies already, including in Pakistan. So one issue that arises is the potential that then it becomes gamed in the content in terms of being informative about the person is not all that high, right? So it's fairly easy to figure out what the correct answers are to a personality quiz in terms of portraying yourself more favorably. And there's really no cost to being dishonest. So I can represent myself as the ideal type of employee just by, giving you the answers that you want to hear. And in fact, there are examples of this. So I think that it's a promising direction, but I think that kind of careful attention has to be paid to this issue of people having to really kind of reveal who they are truly. But that doesn't mean that I think that so beyond diagnostics, the additional avenues I pointed out I think are actually quite promising. So just knowing a little bit more about who people are when we try to design incentives, or knowing that, and so now we have research which establishes that kind of the profile of folks who are going to draw into the public sector in the first place changes a lot depending upon the features of the jobs themselves. So, I think beyond diagnostics, just information that personalities are relevant to performance is kind of useful in a number of applications.
Great, thank you. And a question from Megan, were you at all concerned that this new monitoring scheme could be manipulated by inspectors or ADOs to single out centers or doctors they didn't like?
So that's a good question. So it does definitely provide more information on kind of doctors that are underperforming. And so we surely got anecdotes about inspectors saying, there is a doctor who never goes to work, and so I tried to provide kind of a repeated set of inspections documenting that he wasn't there so that you would have information that this was true. So yeah, it's definitely the case that folks could be singled out, but I think what they're being, I don't have deep moral reservations on this one, because I think what they're being singled out for is for not doing what they're supposed to do, which is be in their clinic. So, I don't see the potential for malfeasance as being that terrible. I mean, all the EDO can do, literally what he's limited to in terms of the technology is all he can do is report whether or not the guy is there and take a picture of him. So, yeah, I mean, maybe they exercise some discretion between two doctors who aren't at work in the first place, but I don't think it's a big issue.
So I have another question from Justin. And he says that you found that smartphone monitoring did have a positive effect on attendance in some areas. And he states that in an ideal world, findings such as this could go on to create a new culture or ethos that improves public employee attendance in and of itself. So in reality, we see that these programs often only work at the intervention mechanism. So in this case, smartphone monitoring is sustained. So do you think there's hope for a culture change to improve attendance such that smartphone monitoring becomes irrelevant? Or if so, how do we get there?
That's a good question.
Yeah.
I mean, so I think that it's a very thorny issue, and not just in this context. As I said at the outset, this has proven to be very intractable. In a separate but related project, we talk a little bit about the political roots of this and have evidence that it seems like these jobs, part of the reason that reporting requirements are so minimal in these jobs is because they're actually used to some degree as patronage by politicians. So they give them out to supporters. And there's actually a long history of this in developed countries as well. So if you are in power and in office, you can give out favorable public sector jobs where you draw a salary but don't have to show up to work in the first place, using the authority of your office. And so, I think that there's a lot that has to change in order for there to be kind of a sea change in the equilibrium. And in fact, even in this program, right, we saw over time, even among the inspectors, we saw attenuation in the rates of inspection. So I don't, I guess I think that the roots of the persistence of absence are actually deep and potentially rooted in the political process itself. So I surely would be the last one to advocate for that a smartphone system, but in and of itself, is going to be enough to change the equilibrium.
Great, thank you. So we have another question from Noor asking, how does actively recruiting for favorable personality types compare to things like providing financial incentives or pay per performance type interventions?
So this is a great question. I mean, if you look at the Dalboa, Finan, and Rossi study, you find that they're sort of the same thing. So it's definitely true that better personality types show up when you offer better wages. So the Weberian view is we don't want to attract financially motivated types into public service. What we want are folks who are intrinsically motivated. And so the financially motivated people in the world should be in the private sector. That's where they're going to do their best work. And the people who are intrinsically motivated or very pro-social should be in the public sector. I think Fred Fanon and Ernesto Dalbo and Martin Rossi's paper shows us that actually the opposite is true. If you raise wages, at least if you buy what these personality measures give us, raising wages draws in better types. Likewise, in Nava Ashraf, Oriana Bandiera, and Scott Lee have a study, and their study finds that people who are drawn to public sector where the advertisement drawing them in explicitly emphasizes kind of career rewards rather than pro-social rewards, those types do better as well. So I think we now have kind of, accumulating evidence that one, increasing wages or increasing kind of the career potential is not going to deter the good types from coming in. In fact, it's going to do the opposite. It's going to draw good types in, and then subsequently those types perform better. So I think that, they're recruiting on personalities or recruiting on wages may wind up giving you the same outcome in any case.
So thank you. Looking back at doctor attendance, so if the doctors were to show up, in your data set, are they actually qualified to provide the health services that patients require? So, and if so, why would doctors go through the trouble of getting certified if they don't intend to show up?
So that's a great question. There is some evidence on this in India. So as an aside, basically when the doctors aren't present in our samples, so I quoted this absence rate of 68.5%, usually, at least anecdotally, what they're doing is they're moonlighting, so they're working in a private clinic. And so, they are quite qualified. It's also true, so there's a study in India by Jishnu Das and co-authors that shows that the same doctor will provide a lower quality of healthcare services in the public sector, in his public clinic, than he will in his private clinic. But yeah, these doctors are qualified. They have to pass tests and be certified in order to perform. They are capable of delivering services. So I think, why would they go to the problem of getting certified if they didn't intend to show up? Well, one cynical answer would be, if you are certified and you have a public sector job and can simultaneously operate your private clinic, you get a public sector salary, but you don't have to report to duty to receive it. And then, everything you earn in the private sector is just gravy beyond that.
Great, thank you. So we do have time for a few more questions. So again, if you do have a question, please click on the green bar at the top of your screen and enter your question through the chat box. Now, you mentioned earlier in your presentation about the cost effectiveness of this intervention and how it was a very cost-effective intervention. How much did the smartphone technology play into that cost-effectiveness analysis? Was that an expensive part of the intervention, or?
No, actually, it was pretty cheap. I mean, so smartphones are getting cheaper all the time. They've even decreased since the time of this study. And the 57K British pounds number I quoted, actually a lot of that was devoted towards research costs, towards data collection and so on. So in fact, I mean, all we needed, so our experimental sample comprised 90 inspectors, and so for those guys, we had to give each of them a smartphone. I mean, you could reasonably, an upper bound on that would be about $100 a phone, so for $9,000, you're up and running. And then, there's some costs related to hosting the server that hosts the data and building the dashboard and so on. But I mean, really, this is, it basically peanuts. I mean, it's still the inspectors have to be paid and so on. But I mean, by any measure, it seems like even just given a short-term bump, this is pretty cost effective.
Great. And related to that, do you think that your findings are applicable to settings where maybe less advanced technologies are available? Or are more readily available, and if so, how?
So yeah, connectivity does wind up being a big issue for this. I think just kind of how well the smartphone technology works depends a whole lot on connectivity and whether or not the actual entries are going to go into the dashboard depends a lot on whether or not there's kind of a network there to support it. We've done this, though, in a pretty broad set of contexts, and in many of them, including Punjab, where connections were really a big issue. So we've also done a comparable thing in Uganda, working even in the most remote parts of the country. And so, our solution has been to just set up the program so that all of these entries just live in the back end in the phone until they get back into a network where they can be transmitted, and then they get transmitted up. So, I think, if we can do them in these environments, then it's only going to get easier. So I guess rural Punjab is probably, in terms of connectivity, about as hard as it gets.
Looks like we have another question from Saifullah. So did you measure health effects? So did you measure the effects of smartphone monitoring on real health service provision? Like maybe the doctors are coming in more but not treating patients, or encouraging the patients to come to their private clinic?
So this is a great question. Our ambition was to do exactly that. So what we wanted to do was just draw a sample of clinic users and then see if we could detect a change in health outcomes. Ultimately, the reason we didn't do exactly that, and this is kind of a core question of interest, is we just didn't have the funding to do it. I can't say anything about the impacts of this on real health outcomes of patients beyond just pointing to the data I mentioned in the slide, that it does seem like having these places function is important. But so the answer, Saifullah, to your question is I don't have the data to answer, to provide a real answer about effects on actual health outcomes.
Great, thank you. So it looks like that's all the questions we've gotten. We'll maybe give you another 30 seconds to, it looks like we just got another question from Kathy. So in terms of the technology, maintenance, and upgrades, what are the ongoing maintenance considerations of the phones, the rechargers, the software, or replacement? Is there capacity when upgrades to dashboard are necessary to upgrade damaged phones? And what is the long-term plan for the next 5 years in maintaining these technologies?
So first thing I would say is that now, so this program has been transitioned to the Punjab Information Technology Board, and they've scaled it to apply to all of the districts in Punjab. So it's now a province-wide program. There are no longer any controlled districts. What are the ongoing maintenance considerations? I guess kind of bearing in mind the costs I quoted on what it would cost to set it up in the first place, I just don't see the recurrent costs as being that high. You're going to have to bear the recurrent costs of paying the inspectors and so on in any scenario, no matter how they're collecting data. And the phones, even if you replace the whole system every single year, you'd be talking an upper bound of like $20,000, which you surely wouldn't need to do. But I do think there is the issue of ownership, right? So basically, it worked really well while our team was pushing it forward, and I think it's because we wanted as a proof of concept to see how it would work under best case scenario. I think it's been carried forward very effectively, but like anything, and this isn't at all specific to this project, it's not going to work well going forward. But I would say the recurrent maintenance costs of this thing are also quite cheap.
Great, thank you. So it looks like that's all the questions we have for today, and I want to take a moment to thank Michael for sharing his research today, and for all of you out there listening for joining and sending in your questions. For anyone you know who missed the presentation who might be interested in the content, we'll be posting the recording from today on our YouTube channel in the coming weeks. If you have any feedback on the webinar, we'd love to hear it. You can share that via email at webinar@povertyactionlab.org. And again, to hear about upcoming research webinars or events or other news from JPAL, we encourage you to visit our website or follow us on social media on Facebook and Twitter. So thank you again, everyone, for joining, and see you at the next webinar.